morning to all of you once again, and welcome to the Department of Urology, Savai Man Singh Medical College, Jaipur. We'll start our teaching class. Today's topic is renal infections, and the presenter is our resident, Dr. Lokendra, and the moderator is Dr. Somendra Bansal, our faculty. So I request Dr. Somendra to kindly ask Dr. Lokendra to present.
A very good morning, all of you. Today, in continuation of our teaching program, there is class on the kidney infection, which will be presented by Dr. Lokendra. I will request Dr. Lokendra to start his presentation. Dr. Lokendra.
Good morning, good morning, teachers and my dear colleagues. Myself, Dr. Lokendra, presenting seminar on kidney infections. Renal infections are less prevalent than the bladder infection, and they are difficult to diagnose. The renal infection can present classically with history of acute onset of fever with chills and rigor, or can have a non-specific symptom like abdominal pain and having a nausea and vomiting along with mild abdominal discomfort, or can have a total asymptomatic presentation. The bacteria and pyuria, which are hallmark of UTI, are usually not predictive of renal infection, and in patient with significant infection may have a sterile urine if the infection is not connected to the PCS, or if there is an obstruction to the ureter. The pathological and radiological criteria for diagnosing renal infection may also be misleading. Some of the chronic renal infection may mimic malignancy on the radiological examination. The effect of renal infection on the renal function is also varied. Various types of upper urinary tract infection are pyelonephritis, which may be acute or chronic, renal abscess, renal-free abscess, emphysematous pyelonephritis, pyelonephrosis, Xanthogranulomatous pyelonephritis, tuberculosis, renal malaria, and others like echinococcus, and fungal infections. Acute pyelonephritis, it is defined as the inflammation of the kidney and the renal pelvis. Diagnosis is made clinically. The clinic spectrum ranges from the gram-negative sepsis to cystitis with mild pain. The classical presentation of the pyelonephritis is that of abrupt onset of fever associated with chills and rigor with flank pain, and there is a costovertebral angle tenderness on physical examination. Sometimes it may be accompanied by dysuria, increased urinary frequency, and urgency. In 75% of the patients, there is a prior history of previous lower urinary tract infections. And the laboratory diagnosis, in the complete blood count, there is a leukocytosis with predominance of neutrophils, and there on urinalysis there is a presence of numerous WBCs, and in urinary sediment there is a presence of granular or leukocyte cast as shown in the figure. In the bacteriology, urine cultures are usually positive, but in about 20% of the patient, when the colony forming count is less than 10 raised to power 5, they may stain negative on gram staining. Imaging is usually not necessary, but in certain conditions, when the diagnosis is uncertain or patient presented with severe symptoms, or patient is severely ill, or in atypical clinical situations like having unresolved infection in children, in diabetics, and in male gender, the imaging is usually required. It is used to rule out the obstruction and to evaluate the source in a recurrent pyelonephritis. In ultrasound, there is a focal parenchymal swelling along with the regions of increased or decreased echogenicity as shown in the figure. And thus, on the contrast and CT urogram, there is areas of hypoattenuation with hyperattenuation, giving the appearance of a striated program on the CT images. The management depends upon whether the presentation is complicated or uncomplicated. In uncomplicated, when the patient is not ill and can take oral treatment, then the oral antibiotic is started for 7 to 10 days, and the patient is evaluated in after 3 to 4 days. If there is clinical improvement, then patient is asked to take the oral treatment at home. But if there is no improvement within 3 to 4 days, then the patient is started on parenteral antibiotics. And if the presentation is of that of complicated pyelonephritis, and if the patient is severe ill enough for to hospitalize, then the patient is hospitalized and uh, injectable antibiotics are started, and the patient is reevaluated after 72 hours or with again a radiological examination to assess whether is there any obstruction or abscess, uh, and then accordingly managed. And the follow-up, the repeat urinary cultures are done over 5 to 7 days of antibiotic therapy, and after 14 days after discontinuing the antibiotic therapy. In that 10 to 30% of the patient, the relapse on after 14-day course of therapy that are usually cured by giving again a 14-day course, but in some of the patient, a longer course of 6 weeks may be required. Complication of acute pyelonephritis can be a renal abscess, perinephric abscess, emphysematous pyelonephritis, pyelonephrosis. Chronically, they may cause chronic pyelonephritis, scarring or atrophy of the kidney, Xanthogranulomatous, myelopathy, and papillary necrosis. The renal abscess, it is the collection of purulent material that is confined to the kidney. Before the use of antibiotic, most of the renal abscess were caused by gram-positive bacteria like staphylococci. After the antibiotic era, the usual organism were because gram-negative organism. Most commonly, they are coliforms like E. coli, Klebsiella, Proteus, and Pseudomonas. These are renal abscess are usually caused by the ascending infection because of complicated UTIs associated with stasis, alkali, pregnancy, or in the neurogenic bladder and in diabetic patients. The presentation is similar to that of acute pyelonephritis. In the laboratory workup, there is a marked leukocytosis, and urine cultures are usually discordant because if the infection is because of hematogenous cause, and the urine cultures are usually discordant. In the USG, there is a rounded thick wall cystic mass with debris and echo-free or low echogenicity space occupying lesion with increased transmission is seen. And the CT is the investigation to delineate the extent of to delineate the tissues, and in it there is a well-defined before and after contrast agent enhancement. In the chronic renal abscess, there is a presence of a ring sign, which is due to increased vascularity of the wall of the abscess. In the management part, it depends upon the size of the renal abscess and the clinical condition of the patient. If the size is less than 3 centimeters, the antibiotic alone may be suffice. And if there is 3 to 5 centimeter size and the patient is stable enough, then it can also be managed conservatively. And if the size is more than 5 centimeters, then percutaneous drainage is offered. But in immunocompromised patients or when the patient is severely ill, the size of renal abscess of any size should be drained. In the perinephric abscess, it is the collection of purulent bacteria that is contained in the ureterous fascia. But when it ruptures through the ureterous fascia, the abscess become perinephric. Diabetes is present in about 1/3 of the patient. Most common organisms are again E. coli, Proteus, and Staph aureus infection. Various causes for it are the rupture of acute cortical abscess into perinephric space, infection of the urine, obstructed urine, and hematogenous spreading mostly from the skin infection. It can also occur because from the surrounding organs from the surrounding organs like that in inflammatory bowel disease, thoracolumbar spine osteomyelitis, and bowel perforations. Clinical presentation is also similar to that of pyelonephritis. Sometimes a palpable mass may be present, and the differentiating picture from pyelonephritis is that in the pyelonephritis, the symptoms are usually less than 5 days, and after taking the antibiotic, patient usually resolves after taking antibiotic therapy in pyelonephritis. But in a case of perinephric abscess, the symptoms are present for more than 5 days, and after starting antibiotic on a pyelonephritic patient may not have improved, And then think of the perinephric abscess. CT is particularly valuable for demonstrating the extent of the abscess. As shown in this, the abscess is extending to the flank region and to the psoas muscle. There is the CT showing the abscess extending to the adrenal gland. Management again depends upon the size, and in it IV antibiotics should be started as early as possible. And if the size is more than 3 centimeters, then percutaneous or open drainage should be done. And nephrectomy should be done in the case of a severely infected or the kidney is non-functioning. Pyelonephritis. In the infected hydronephrosis is the bacterial infection in a hydronephrotic kidney, and the pyelonephrosis is there when there is suppurative destruction of the renal parenchyma that is associated with total loss or near total loss of a renal function. Clinical presentation is like that of pyelonephritis, but in the patient is serious, very ill and may require hospitalization. In the radiological examination, in the infected hydronephrosis, there is a presence of internal echoes along with fluid debris within the dependent portion of our dilated pelvic system. In a case of pyelonephrosis, there are areas of decreased echogenicity in the parenchyma of the kidney. CT is a non-specific but may show thickening of renal pelvis and the stranding of the perirenal fat, and a striated nephrogram can also be seen. Here is the ultrasound showing the hydronephrosis with echogenic debris suggestive of pyelonephrosis. Here is the cross specimen of a pyelonephrotic kidney. Here the parenchyma is lost, and along with dilated pelvic system and calyces. Again, in the management part, rapport diagnosis should be there, and appropriate antimicrobials should be studied as early as possible. And drainage of the infected pelvis, if it is suspected to be infected hydronephrosis, then a DJ stent can suffice. But if there is a obstruction or if there is a pyelonephrosis, then because of the thick pus, then nephrostomy tube should have a better drainage. Emphysematous pyelonephritis, it is a urological emergency which is characterized by acute necrotizing parenchymal and perirenal infection by a gas-forming uropathogen, especially it present in a diabetic patient, especially in women. Presentation is similar to that of acute pyelonephritis, but it has a pulmonary course as compared to acute pyelonephritis. Its the usual age of presentation is around 55 years, more common in women. Uncontrolled diabetes is a significant risk factor for the emphysematous pyelonephritis. Usually, urinary tract obstruction is also present. Left kidney is more fat than the right, and bilateral cases are also seen. Other factors which are associated with development of emphysematous pyelonephritis are drug abuse, neurogenic blood, having alcohol intake, alcoholism patient, and when there is an anatomic anomaly like in PCKD disease. In the etiology part, again, the gram-negative organisms are the most common cause for emphysematous pyelonephritis, but in mixed organisms, they are present in about 10% of the patient, and really fungi can also cause emphysematous pyelonephritis. In the pathology part, there is a uncontrolled diabetes because of the increased glucose within the tissue. There is a presence of a gas-forming microorganism, and there is impaired vascular blood supply because of diabetic microangiopathy, or the immunity of which is compromised, or there is a presence of obstruction in the urinary tract. And the clinical presentation, there is a fever, abdominal or flank pain associated with systemic features like nausea and vomiting. Acute renal impairment can also present. Patient may also present with altered sensorium or in shock, and then there can be aneupituria when the PCS is connected to the pyelonephritic system, and in the severe cases there can be subcutaneous emphysema along with pneumomediastinum. But juvenile diabetes is not a risk factor for the emphysematous pyelonephritis. Mortality rate is again ranges from 19 to 43%, and it is a radiographic diagnosis. And CT is a procedure of choice to guide the extent and guiding management. In the laboratory findings, there is leukocytosis, pyuria, there is usually positive urine culture, thrombocytopenia, increased creatinine, and positive blood cultures. In X-ray, there is a presence of a motile gas within the renal fossa, presenting gas collection within the girotrasphagia. There can be a linear gas shadows along with the paraspinal region. In ultrasound, there are coarse echoes within the renal collecting system, or there can be a dirty echogenic foci with ring down artifacts that represents AR may also be seen. According to CT, they are classified according to one at all. They on CT base they are classified in two types. In type 1, that is also called dry type. More than there is destruction of more than 1/3 of the renal parenchyma. There is a streaky or motile gas seen, but the intra and extrarenal fluid collection are characteristically absent. It is having a very aggressive course, and the mortality reaches up to 50 to 70%. In type 2, there is destruction. The destruction is less than 1/3 of renal parenchyma, but it is associated with renal or extrarenal collections with bubbly or loculated gas within the PCS or ureter. Mortality is in this case is 20%. But according to the Hong and Tsang, it is classified into 4 types. In type 1, there is a collection of gas in the PCS. In type 2, there is collection of the gas in the renal parenchyma. In type 3A, the gas extends to the perinephric region. In type 4, the gas extends to the paranephric region. And in type 4, the emphysematous pyelonephritis may present bilaterally, or when the emphysematous pyelonephritis present in a solitary kidney. Then the management part, the antibiotic selection can be done according to the class and according to the presence of the risk factors like thrombocytopenia, increased creatinine, altered sensorium, and shock. And the class 1, where the third generation cephalosporin along with amikacin, and the drainage is optional. In class 2, 3, and 4, when there is no risk factor, then again antibiotics are third generation cephalosporin, but drainage is required in this class. And in when the in class 2, 3, 4, when there is the presence of risk factors, the carbapenem is usually started along with the drainage of the PCN. The indication of nephrectomy is the treatment of choice in many patients when the presentation of the emphysematous pyelonephritis is of dry type and when there is a presence of risk factors. These are the factors which are associated with poor prognosis, like patient presented with altered sensorium and in multi-organ failure and uncontrolled diabetes. In the chronic pyelonephritis, is usually caused by the reflex of the infected urine in their childhood, recurrent infection, a history of analgesic abuse, calculi or obstruction. Chronic pyelonephritis secondary to a UTI is a rare when there is absence of structural and functional abnormalities of the kidney. The clinical presentation, it can present with no symptoms to when the chronic renal failure symptoms. On imaging, there is on IVP, there is asymmetry and irregularity of the kidney outlines. There are the blunting and dilatation of one or more calyces and cortical scars at the corresponding sites. In the CT, there are cortical scar and blunted calyces, which are usually polar in location. The pathology part, the kidney is diffusely contracted, scarred and pitted. The scars are Y-shaped, flat, broad-based depression with red-brown granular bases. In the microscopically, there is infiltration of leukocyte and hyaline cast, giving the appearance of a thyroid chloride, and signal thyroidization is seen in the microscopy. The management part, treating the infection if present, preventing future infections, and monitoring and preserving renal infection. Because of chronic pyelonephritis, antimicrobial therapy is often prolonged, and the appropriate nephrological and urological evaluation should be done to rule out the cause of chronic pyelonephritis. And Xanthogranulomatous pyelonephritis, it is a rare, severe chronic renal infection which causes the diffuse renal destruction. It presents as a unilateral. It is usually unilateral and results in a non-functioning enlarged kidney that is associated with obstructive uropathy secondary to a nephrodethesis. It begins within the pelvis and calyces and then extends to the surroundings. It mimics inflammatory disease of the kidney, other inflammatory disease of the kidney, and renal cell carcinoma on radiographic examination. It commonly present in the 5th to 7th decade, more common in women, and there is no predilection for either kidney. Risk factors associated with XGPN is nephrodethesis, diabetic, and patient has history of recurrent UTI, or there is a history of urological instrumentation. There is the chronology for Xanthogranulomatous pyelonephritis. First of all, there is a chronic urinary infection, and then there is a deposition of ammonium magnesium phosphate in the PCA, which leads to chronic urinary obstruction, and then an inflammatory mass is formed in the adjacent renal parenchyma, and then this inflammation extends to the extrarenal region. Macroscopically, there there can be a nephrolithiasis, peripelvic fibrosis. The peripelvic fibrosis prevents the dilatation of the pelvis in this, and there is a calcium dilatation with pus. There are usually multiple parenchymal abscess and with yellowish tissue. Cortex is thin, often replaced by a xanthogranulomatous tissue. There is thickening of capsule and inflammatory extension into peripelvic and parapelvic space is also seen. Microscopically, there is a presence of yellowish nodules, and there are lipid-laden macrophages that are intermixed with lymphocyte and giant cells and plasma cells. Staging part, the first XGPL is when it is contained within the kidney. In second stage, it is extending to the perinephric region. In stage 3, extends to the perinephric spaces. Its in type, its present diffuse presentation is seen in 80% of the patient, and segmental can also be present in 20%. Clinical presentation is like that of flank pain, fever with chills, essence bacteria, and a flank mass can also be there. There can be also hypertension, hematuria, and vague symptoms also there. In the laboratory diagnosis, urine culture is positive in approximately 1/3 of the patient. Most common organism in this is Proteus. In the urine, there can be pyuria, proteinuria. Anemia and hepatic dysfunction are present in about 50% of the patient. Frank renal failure is uncommon as the disease is unilateral, mostly unilateral. In the city, there is a classical triad of unilateral renal enlargement with little or no function, and there is a presence of a large calculus in the renal pelvis. In the a beer paw sign is seen on the CT, as shown in the CT, and there can be a massive caliectasis. On ultrasound, there is a global enlargement along with multiple hypoechoic fluid-filled calyces seen. On the nuclide scanning, the technetium DMSA scan is used for differential function. MRI can show the extrarenal extension. On the T1, it appears as an intermediate intensity signal. On T2, it appears as a hyperintensity signal. But no radiological investigation can differentiate between xanthogranulomatous pyelonephritis and renal cell carcinoma. Management in the management part, first there should be primary obstacle to correct treatment is incorrect diagnosis. With a CT scan, approximately 90% of the cases can be diagnosed, and antibiotic therapy are started to stabilize the patient appropriately. And in this long course of antibiotic therapy can eradicate infection and restore renal function. Percutaneous dialysis is not advised because it is not curative. A nephrectomy is usually done, but in a case of a segmental xanthogranulomatous pyelonephritis, partial nephrectomy can also be done. Left nephrectomy can be done with a high conversion rate. Renal malacoplakia, it is defined as a soft plaque, originally described by the Michael and Gutman, and is first described to the bladder, but has been found to affect the other symptoms like genitourinary, GIT, skin and lungs. It is an inflammatory granulomatous lesion. It is characterized by von Hessman as soft yellow-brown plaques with Michael Gutman bodies, which are the histiocyte and contain distinct basophilic lysosomal inclusion bodies. It results from abnormal macrophage function in response to a bacterial infection, most commonly E. coli infection. It is hypothesized that.
Why are you reading verbatim? Within you are reading word to word, verbatim, line to line, verbatim.
Calcium phosphate crystals that laminate the Michael Gutman bodies. Clinically, presentation is it presents in more than 50 years of female. Male to female ratio is 4:1. Patients are often immunocompromised, and it is a molecular plakia is rarely seen in HIV infection because of the preserved macrophage function in the HIV patients. It present as a palpable lump, and on the radiograph there are radiograph masses, and the patient also has a history of E. coli infection. It can be complicated by a renal vein thrombosis and inferior vena cava thrombosis. In the pathology, there is a presence of a von Hessman cells, which are large histiocytes, and it contains small basophilic, extracytoplasmic, intracytoplasmic calculus, also called Michael Gutman bodies. Michael Gutman bodies can be absent in early stages of the disease. And macrophages in malacoplakia contain alpha-1 antitrypsin, which can be used for diagnosis In radiological examination, the kidneys are usually enlarged with multiple filling defects. The renal calcification and the stones and hydronephrosis are usually absent. On ultrasound, there is renal enlargement, and on arteriography, it typically reveals a hypovascular mass without a peripheral vascular neovascularity. In the CT findings, the disease can present unilateral or bilateral. There is a focal or multifocal or diffuse presentation. Infiltrating masses are also present. Renal values may or may not involve, and the foci of myelococplakia are less enhancing and less dense than the surrounding enhanced parenchyma. Management depends on at the control of UTI with antimicrobial agents. Some antibiotics like sulfonamides, rifampicin, doxycycline, and trimethoprim are helpful because of their intracellular bactericidal activity. Fluoroquinolones are also intracellular bactericidal activity and also effective. The ascorbic acid and cholinergic agents are also used because they increase the cyclic GMP in this, which helps in the function of the macrophages. In the management part, if the disease progresses in spite of antimicrobial therapy, then nephrectomy should go for. And when the disease presents bilaterally in a transplanted kidney, that usually occurs within 6 months, and patients with unilateral disease have a long-term survival after nephrectomy. Renal echinococcus, it is usually caused by echinococcus granulosis and location usually single located in cortex. It presents as a slow-growing tumor at the rate of 1 centimeter per year. Most patients are asymptomatic or may present with a blank mass. Hereditary can be present if the cyst ruptures in the PCS system. Half of the patients may present with diarrhea. Hydrated R5 antigen in a double division method is used for diagnosis. Here is the slide showing the hydrated cyst and the daughter cyst. In the imaging part, here is the CT showing the hydrated cyst in the kidney as well as in the liver. In the management part, it says as good prognosis. Medical management is with the antibiotic mebendazole and albendazole, which are associated with significant side effects. But surgery is the main step for the treatment. Cyst should be removed without rupturing. But if the cyst cannot be removed, or if the cyst during surgery the cyst is ruptured, then marsupialization can be done, which after which the polycidal agents like sodium chloride, nitrate, and formalin iodine are used to kill the general portion of the cyst. In the fungal infection are usually seen in an immunocompromised host, and it is it presents a severe life-threatening infection in them, and the patient are usually diabetic and having a hematological malignancy. Most common organisms are Candida and Aspergillus. It present as a multiple renal abscess. There is a mass of because of conglomeration of fungal hyphae and inflammatory cells into a fungal ball. In mucormycosis, it is a rare, but can also be present as a part of a disseminated disease. And isolated cases of mucormycosis are reported in a case series of case reports. Clinical manifestations are similar to that of pyelonephritis, and in the radiological features, there is a tendency to invade the vessels and cause infarction. There is the CT showing the invasion of the renal artery and renal vein. In the diagnosis part, usually it is diagnosed by biopsy or FNAC, and the fungal stains used are for the periodic acid stuff, and Gorofords, methamine, silver stain are used for diagnosis. Treatment is in the treatment part, the combined antifungal therapy and surgery are used. The antifungal used are amphotericin B and posaconazole, but it is associated with a high mortality rate. In the HIV patient, the Pneumocystis carni presents as a diffuse and punctate calcifications in kidney.
Thank you, Lokendra. And we will take some questions, queries from residents and faculty. And Nimish, has anybody joined from outside? Let me know if somebody has joined. Yes.
No, sir.
So renal infections are again a very important chapter which is often neglected, and we usually do not read or present on this particular topic because sometimes these infections could be fatal also. So as Dr. Lokendra said, a few things about the diagnosis that he mentioned in his slides. One is that you should not miss blood culture, because many of these kidney infections are usually a systemic infections and they may not be picked up by urine culture. Usually, because many a times the urine may be sterile. Secondly, many of these patients which are hospitalized and catheterized, so this catheter-induced infections will be picked up rather than the actual systemic renal infections. So blood culture is a must in most of these renal infections. Secondly, he said imaging is usually not required. That is not correct. Imaging is a very important part of diagnosis of renal infections. There are so many infections which will exactly tell you on imaging and what kind of infections, whether there is a renal abscess, perinephric collection, and the other infections that actually can be characterized on CT imaging. So imaging is a very important part of renal infections, right? And you should always remember there are few infections which could be fatal, right? So one of them is the emphysematous pyelonephritis, particularly in diabetic patients which are uncontrolled diabetes. So be very careful about patients with emphysematous pyelonephritis. We have to be very aggressive in their treatment. And other important, which is maybe surgically also maybe very difficult to operate, is the Xanthogranulomatous pyelonephritis. So XGP on imaging, yes, it may be difficult sometimes, as Lokendra said, but definitely because there is always a stone along with that mass lesion. So you can actually suspect that this could be a case of Xanthogranulomatous pyelonephritis. So this again could be a very difficult, not only to treat, but surgically to remove these kidneys again could be a very big challenge. Then the other infection which could be very fatal is what he said about the mucormycosis. We have not look at so we should have had an important slide on fungal infections, because kidney fungal infections are also known, particularly in patients who are immunocompromised, post-transplant, diabetic uncontrolled. So candidiasis, aspergillosis, and in COVID, we know mucormycosis came in so many patients. So, mucormycosis is the most common is the rhinocerebral mucormycosis, then it's pulmonary, cutaneous, and isolated renal mucormycosis. There are a lot of case reports also, and this could be fatal. So very important to diagnose mucormycosis of the kidney if you suspect, and the treatment has to be very aggressive. Either if the kidney has not been destroyed, there is no collection, you may try conservative with amphotericin, etc. But many of these patients may require nephrectomy. So it's very important to, and then so you should have done viral infections of the kidney, because post-transplant there could be viral infections, CMV infection, etc., which is again a very important part. So renal infections, again, we must understand, and so that we can actually treat these patients properly. When you talk of antibiotics, definitely we need to take care of gram-negative bacilli and Staph aureus, which is usually a methicillin resistant. So antibiotics should be started empirically, saying these two antibiotics has to be taken care of. So usually piperacillin, tazobactam, meropenem, etc. are good antibiotics to start with. But if it is a hospital acquired, then definitely you should have a proper antibiogram to know which antibiotics are sensitive and resistant to start empirically this treatment. Otherwise, we need to have a proper blood culture to dictate our antibiotic therapy. So I think that was it. And if you have any query, Dr. Nachiket, would you like to say? Just come here.
I think that we overemphasized on mucormycosis.
Come here.
Mucormycosis itself was very rare before COVID.
No, I told him.
So I think that the most important thing for you to cover in fungal infections of the kidney would have been Candida, because Candida is one of those fungal infections that you see routinely inside practice, right? So I think that mucormycosis, actually it has been rare in front of Candida, because you get it every day. So if you would have stressed upon Candida as an infection, because you see it inside your practice, you see it in transplant, more common than mucormycosis. How do you identify what is the colony count for Candida, and how do you stain Candida? So this would have been the thing. Secondly, I think that you should not read verbatim again from these slides. I don't know why you are continuously reading verbatim, and this has been told that you should just take cues from this slide. And tuberculosis itself is a separate chapter, so we'll have to discuss it later on.
Yeah, very correctly said. Mucormycosis, I told you because I have a patient of mucormycosis now, and he has been diagnosed as isolated, which is actually could be fatal also. So what I meant was you should have a particular section of fungal infections. So not only mucormycosis, it was fungal infections where you should have mentioned about mucormycosis also. And then you should have a section on viral infections of the kidney. Right? And tuberculosis, don't miss tuberculosis. When we present on renal infections, we are not just talking about acute bacterial infection. We are talking about all kinds of infections of the kidney. And tuberculosis in our country is a very, very important topic. So genitourinary tuberculosis, renal tuberculosis is definitely a very important thing you should not have missed, and you should have given at least tuberculosis also. So I think that's it. And if you have any query, students. Okay, Nimesh, do we have anybody from outside?
No, sir.
Okay, thank you. So, Dr. Somendra, come. I will request our moderator now to sum up and wrap up the session.
Thank you, Shivam sir and Nachiket sir, for their excellent discussion and on the brief on this topic. And thank you all, Radiant, and very nice presentation. We don't cover the tuberculosis in this lecture because this is a separate entity, and this we will take extra class on this.
How do you tend to control the menace of these people reading the slides for that? How do we as consultants? I mean, it's against the norm of a presentation. I mean, this has been discussed.
Yeah, thank you. Thank you, Somendra. We will discuss it. This is a thing which has to be developed. This kind of a culture where the resident should know how to present, right? This is a part of your training. So Nachiket has very rightly said that just don't read verbatim. If you actually want to excel, you want to go ahead later in conferences, workshops, CMEs, etc. You want to present. This gives a very poor impression when you read the slides. So try to learn how the presentation is done.
So I want to
it's very important.
Forward a solution to this.
Yes.
I think that first of all, they should send the slides 24 hours before the presentation. Secondly, their slides should only have the headings, and then they have to be the fillers things.
Right.
For example, if he said renal mucormycosis, then that is it. Only renal mucormycosis.
Yeah.
A little bit of
So we will take your suggestions. In the meantime, thank you all the residents. After all. So thank you residents and faculty members and all those who might have joined us today on Zoom and YouTube. So we will end this session today and have a good day. Yes.